It is a great pleasure for me to introduce them to you so they can speak with you about their research called Reviving the Unexpected Victim of the Pandemic, Resident Education. Please join me in welcoming them.
This is a true story, as told by one of the attendings from our institution in spring of 2022, 2 years into the COVID-19 pandemic. It was the middle of the night in the PICU, and a patient was rolling in to be admitted, clearly in respiratory distress despite continuous albuterol. The second-year resident went and took a thorough history, did an examination, and then I asked them, okay, what do you want to try next? And they shyly admitted to me that they didn't know what to do next, and later said that this was actually the first severe asthma exacerbation that they had seen in residency. Now, I knew that the COVID-19 pandemic had impacted the censuses of our pediatric wards and changed the population of the patients that the residents were seeing. But asthma exacerbations were one of the most commonly taught pediatric educational topics. So how did one of our residents make it almost 2 years into their residency without having this education? I felt like we had failed them. Resident education was the unexpected victim of the pandemic. Thank you all so much for joining us here today. We are so excited to see all of your faces. We want to make sure that you know that throughout this talk, when we use the vernacular educational conferences, what we're referring to are the morning reports and noon conferences that we hold on a daily basis. They are semi-protected, formal didactic sessions for our residents that last about 30 to 60 minutes and are meant to supplement the clinical education that our residents are receiving. So go back with us to last academic year, the 2021-2022 academic year. And we realized at that point that our conferences are dying, despite valiant attempts at CPR. And like most real-life resuscitations, things are not always going quite according to plan. So if we start back in November of 2021, at this point, our leadership had realized that something was wrong. There was poor attendance at conferences. They couldn't figure out why. They really wanted to get the residents there. And they sent out this email. I'll read you some excerpts. Dear residents, minutes into the presentation, we only had 4 residents tune in. This was disheartening and, to be frank, embarrassing. We've seen a steady drop off in conferences over the last few months, and several conferences where less than 5 residents showed up, and that includes both Zoom and in person. So you would think that this email would be pretty impactful. Yeah, that was November. December went by, and then now it's January, and we still see our then chief, Dr. John G. Barber, saying there's only 4 people on right now. We all received this Slack message. And then in February, the terrifying event happened, where there was just 1 chief resident present for noon conference given by our chair of pediatrics, Dr. Mary Leonard. Dr. Leonard, on behalf of all of us, yikes. Please accept our sincerest apologies. And then comes March of 2022. Our then senior resident and now PICU fellow, Dr. Anna Brzezinski, had prepared a morning report only to show up and find that nobody was there. Second-year resident Jorge Ortiz Colon stayed post-call from his night shift so that she would have someone to present to. And it was so memorable that they took this picture. Again, chief residents, John G. Barber sent out a Slack saying only 1 post-call resident is here, but nobody came. And he was the lone audience member. April, May, June, the months trailed on and nothing changed. And it was unclear what the barrier was, what had happened to our educational conferences. At this point, we realized that the conferences were past the point of CPR. They needed to be cannulated onto educational ECMO. And so imagine us, we start our chief year in the end of June, beginning of July in 2022, and we're standing over our metaphorical ECMO patient and trying to think of what the plan is for what we're going to do next and how we're going to address this. And so we decide to draw on our years of excellent pediatric training, and we decide we need to take a thorough history and make a broad differential and really figure out what are the problems here that we need to address. So let's take a look back in history and see how we ended up in this place. So we're going to take you back a few years to where Noon Conference was a place of togetherness, laughter, and eating lunch without masks. But then suddenly in March of 2020, the COVID-19 pandemic hit and everything changed with masking protocols, social distancing, and suddenly conferences had to be turned virtual. And we turned to this high-tech piece of technology we all came to know and love as Zoom. We had to learn lots of new things when we did this, including new phrases such as, I think you're muted. And I'm going to share my screen now. Can everybody see what I'm sharing? And as Zoom became an integral part of our education, the videos started being turned off and the participation began declining. Our inpatient residents were Zooming in from the workrooms. And this was incredibly distracting because they had their EMR in front of them. They were being pulled by patient tasks. They were talking to other members of the care team. And eventually they would just not be paying attention to Noon Conference at all. And for those who were rounding, they were no longer physically leaving to go to Noon Conference. And so it was easy for rounds to just continue through noontime and keep going throughout the day without any regard to what time it was or needing to stop for conference. This was also a challenge in the outpatient setting because while residents used to walk across the street to morning report and be there from 8 to 8:30 and then return to start seeing patients at 8:30, now residents were Zooming into morning report from the clinic. And because they were there, they often just started seeing patients at 8. And so slowly it turned into residents start seeing patients at 8 a.m. and don't go to morning report at all. So even when things started returning, that habit had already been formed. 2 years went by. 2 new classes of residents that had never experienced consistent in-person conferences. And slowly but surely over that time, there was a culture shift and there was a change in everyone's habits. And now we were at a point where there was a new norm, and prioritizing resident educational conferences was not a part of it.
Okay, so now that we worked through what happened, we needed to identify if there was tangible consequences or outcomes for our residents that we could measure. And here is what we found. So first of all, we looked at our ACGME survey data. For those unfamiliar, we give this ACGME survey to our residents every year and look at their different perspectives. And we found that within this survey, there was non-compliance with the response to residents feeling protected time to participate in structured learning activities, as well as appropriate balance between education and patient care. The next thing we found was the board passage rates. So this was not just something here at this institution, this was a national problem. And what we saw was across the country, boards passage rates in pediatrics fell. So in 2018, before the pandemic, the passage rate was 90%. And then in 2022, this past year, that's fallen to 80%. And what's interesting is this is actually something very specific to pediatrics. Other specialties like internal medicine, gen surg, anesthesia are not seeing similar trends in falling. And while our averages here at Stanford are above the national averages, we did also see trends downward that mirrored this in both our board passage rates as well as our in-training exams, which we give to our residents annually to kind of gauge general clinical knowledge. And then third, so during the pandemic, and Dr. Sedler highlighted this so beautifully earlier, you know, our adult censuses were skyrocketing. There were overflowing wards on the adult side, but on the pediatric sides, we were at an all-time low with respect to our censuses. And this meant missed learning opportunities. There was less opportunities to learn at bedside and gain that sort of clinical knowledge. And this was happening within the context of not having a strong conference culture to sort of offset those missed learning opportunities. And so that brings us back to the start of our chief year. We knew something had to be done, and we set off to try to improve resident education and identified 3 specific goals. So number 1, our first goal was to improve conference attendance and engagement. Number 2 was to reverse this sort of cultural shift that we were seeing and to increase residents' kind of perception of our overall conference culture as a whole. And then the third was to increase residents' fund of knowledge and clinical reasoning skills. We knew this wasn't going to be an easy process. We couldn't just change a conference. We had to change a culture. And in doing so, that would require multiple levels, all of our stakeholders and such. So with this sort of, now that we've outlined, these problems that we are facing and these clear objectives, for the remainder of our presentation, we're really going to be showcasing the steps we took and the scholarly component of our work. So in trying to make large institutional change, we looked to the literature to find a framework that we felt could help guide us. And we landed on Kotter's 8-step process for change. So John Kotter wrote a book in the 1990s entitled Leading Change. He's former Harvard Business School faculty. And in this book, he outlined the challenges that institutions face in making changes, as well as giving these actionable 8-step items to create change and build change. So here it is, and initially described as a staircase. Scholars over the years have really determined that it's best viewed more as a cycle because change is such an iterative process. So we decided to draw upon this model from the business world for creating change and apply it here to our own institution. And this here is the model we decided to use, and I'm going to walk you through it now and break it down for you. So on the outside, you see the 8 steps for change, which can be summarized broadly into the 3 buckets that you see in the middle. So the first, which you see in blue, is create a climate for change. The second that you see in purple is to engage and enable. And the third is to implement and sustain. We're going to be going through all of our steps over the remainder of our presentation, but just to broadly introduce them to you now, the first is to create a sense of urgency. The second is to build a guiding coalition. The third is to develop a strategic vision. The fourth is to share the vision. 5 is to remove barriers. 6 is to generate short-term wins. 7 is to sustain acceleration. And 8 is to embed changes into culture. So the first step, create a sense of urgency. Hopefully we've already done that for you now, because we certainly felt that sense of urgency when we started our chief year. And our next step was to really communicate that sense of urgency with the same stories we shared with you today with our key stakeholders.
And that brings us to step 2, building a guiding coalition. So we started by trying to form our working team, really looking for advisors and mentors. And we want to highlight some of those people here with you today and what their roles were. On the right, or on your left-hand side, you see Dr. Carrie Rossbach, our program director, and Dr. Kevin Kuo, one of our associate program directors overseeing curriculum. These 2 were our mentors for our project, and really we couldn't have done everything that we did without their guidance. In the middle there, you see Dr. Victor Ritter, who is an extraordinary statistician who we had the honor of working with this year. He was so dedicated. He met with us weekly to discuss our progress on our project, to discuss the trends in our data that we were seeing that when we were collecting it, and to really help guide our methodology. Victor is on with us virtually today. Thank you so much for being here and truly for being with us every step of the way. Then you see Kat Jackman here, who is one of our program coordinators, who is just really instrumental in helping us get our data. And then lastly, Dr. Aydin Zahedovic, right over there, who is one of our rising chief residents who we brought on as a resident liaison to really make sure that we were understanding our residents' perspectives correctly and the feedback that they were sharing with us. And he helped us brainstorm some ideas for interventions as well. After we formed our working team, we went on to try to find faculty that could help champion our vision. And so we want to give a shout out now to the 5 faculty members outside of Carrie who attended the most conferences for us this year. These people are Dr. Mel Balboni, many of them are in the audience with us today. So thank you to Dr. Mel Balboni, Dr. Debbie Sakai, Dr. Lauren Destino, Dr. Kiki Boyd, and Dr. Kate Sutter. You all have role modeled for us continual learning and role modeled being there for our residents, and you so deeply enriched the learning experience for them. So thank you. You already met Carrie and Kevin, but we also had the wonderful support of Dr. Becky Blankenberg, the Assistant Dean of Graduate Medical Education, Dr. Alan Schroeder, who kindly helped to volunteer to help us get our journal clubs off the ground again, and Dr. Mary Leonard, our chair of the department, who took the time to meet with us and truly advocate on our behalf. And we truly couldn't have done everything that we did this year and with this project without this team here, our program coordinators, Carrie Johnson, Michelle Brooks, Carrie McGoy, and Kat Jackman. For the times that we couldn't be there for conferences, these four stepped in for us to make sure that our speakers were set up for success with all the AV tech equipment and that they felt comfortable. And we want to take a moment to acknowledge everybody whose picture was not there, who was really instrumental in supporting us as individuals and as humans, who kept us sane throughout this process as we poured our heart and soul into this project, our blood, sweat, and tears. You all know who you are, and thank you so, so much. Bringing it back to our model, so that was our guiding coalition, and now it was time for us to develop a strategic vision. And so when we did this, we knew that this needed to not just be about the interventions, but also how we collected data on the interventions. Did we know if they were working? Were they helping? What should we do next? We used a mixed method design that we will highlight for you here. So we decided to do a quantitative and qualitative survey feedback, as well as quantitative attendance data and data on our hospital that we collected on a daily basis in a year-long iterative process. We drew on elements of the PDSA cycle. We talked a lot about how much of a quality improvement stance to take here, and I think that we really had inspiration from the Plan, Do, Study Act, even though we were using Cotter's model kind of as our guiding, the guiding principle that we were following. And so we used this a lot to decide how conferences were going and figure out what we needed to implement and change. Over the year, we sent out a series of 5 surveys to the residents, and then after each, we met as a group, we analyzed the data, we reviewed what needed to be changed, and we decided what we should do to respond to resident feedback. Each of those 5 surveys consisted of the same 26 prompts. Some of them were a Likert scale that went from strongly disagree to strongly agree, and assessed things like, did the residents find conference enjoyable? Was their time protected? Did they feel like they were getting prepared for boards? Did things like coffee or the presence of attendings there help influence them to be there? And then we also had some open-ended qualitative questions like, what are your barriers from getting to conference, and what are the facilitating factors that make you want to be there? Here is kind of a basic outline of the timeline that we created for ourselves when we were forming our strategic vision. Our pre-survey we first sent out in June of 2022 to get baseline data and see where we were at before we performed any interventions. And then we sent out 4 more approximately every 2 to 3 months after that. And the little green lines just highlight periods of time where we were looking at what those surveys showed us and then making changes based on what we saw. So in addition to the surveys, every single day we collected quantitative data based on resident attendance and what was happening in the hospital. And we thought it might be helpful to give you a little visual of what that looked like. So it started with us putting together hospital and conference data. We wrote down what the meeting type was, so whether it was hybrid or all in person, what the material type was going to be for the noon conference. So let's say it was going to be lecture or case-based, or we were playing Jeopardy. Not that kind of Jeopardy, residents, don't worry. We talked about whether there was going to be candy or coffee present. And then we also checked the census of every inpatient team, as well as the census of the entire hospital. And then one other intervention that we'll talk more about later is we sent out Volt reminders to our nurses, case managers, and also to our residents of the educational times for the day. So we marked when we had done that. So we did that every morning before morning report, and then we did it again before noon conference. Then during each conference, one chief was assigned to take in-person and virtual attendance. At first, we developed NFC tags that contained resident data for each individual resident that they would badge in. So we either used the NFC tags or we used manual attendance to see who was there in person and who was virtual. And then in this data sheet, coding pulled in each attendee's data to calculate the in-person attendance broken down by class, those who attended who were med students, faculty, or other attendees, and then the total overall in person. We then repeated this process for virtual attendees, also then broken down by class, other attendees, total virtual attendees, and finally the total overall attendees. And then based off this data and ongoing analysis and continual reevaluation, we would adjust the specifics of what we were doing in order to bring us back to these 3 goals and make sure that we were addressing them. So now that we had designed our strategy and decided how we were going to do this, it was time for us to get buy-in from key stakeholders throughout the hospital at every levels so that we could actually make change happen. And so that brings us to step 4, which is sharing the vision. And all of you in this room are probably here because we wouldn't stop talking about this. So thank you for listening to us. We continue to talk to anyone who would listen about our vision. We met with the incredibly supportive Dr. Mary Leonard. We presented at the division chief meeting. We presented to members of the executive leadership team. We spoke with rotation directors. We spoke with nursing staff. We needed buy-in from our residents, particularly our senior residents who are leading our teams, getting them to conference and also giving morning reports. And then we needed support from the literal hundreds of people who signed up to teach at our morning reports and noon conferences. If you were one of the people who taught at those conferences, please know we are so grateful for you and for the support that you provided. All right, that brings us to step 5, removing the barriers, of which there were plenty. So as recent residents ourselves, when we undertook this project, we had already identified some barriers that we experienced as residents trying to attend conference. But we also wanted to ask our residents themselves in those surveys every 2 months, what were barriers that they were facing so we could try to address some of those. In the next few slides, I want to highlight the top 5 things that we tried to address with you, or the top 5 barriers that we tried to address in this project. So the first was quality. We knew that if we were going to ask our residents to come spend time with us in conference, we had to make it worth their while. That in their jam-packed days filled with clinical duties, that they would take the time to come to conference, to learn, and to be with their peers. So how did we do this? First is we had to make what we were teaching relevant to them. So we worked with Dr. Kevin Kuo to build out an 18-month curriculum for our noon conference series, allocating those conference slots to different general pediatric topics that were identified by the American Board of Pediatrics as topics that would be tested on the board's exam every year. And we adjusted those allocations based on what residents in our program might not be getting as much clinical exposure to, and the areas on the in-training exam that they might be scoring a little bit lower in. Second, we heard very loud and clear from our residents that the way they prefer to learn is case-based learning. So 100% of our morning reports were now case-based, and many of our noon conferences have followed suit. We even are super intentional during our case-based discussions to carve out some time to make sure our residents have the opportunity to develop an assessment, just like they would on the wards, making sure that they are able to practice their clinical reasoning skills. Next is that we started to incorporate board review questions. So as you had heard already, on a national level, the pediatric board pass rates have gone down, and locally we saw that too. So we thought we needed to start bringing in board prep from day 1 of residency. So we asked all of our speakers to include at least one board prep question in their talk. This is one example from Dr. Andrew Brennan, one of our co-residents and now one of our cardiology fellows, who gave a talk just earlier this week on telemetry review, and he included this question here. We knew this was a major overhaul on how conferences had been done in the past, and so in order to help prep our speakers, we came up with this very lengthy and comprehensive email that you see here that includes all of those details to try to set them up for success, to build some kind of interactive and engaging presentation for our residents. In this email here, you'll also see that we included a PowerPoint template that they can refer to help structure their talk. All right, the next barrier that was identified was just patient load. And often cited was busy clinics, high censuses, RSV surges, and long rounds. We want to take a moment to shout out Dr. Laura Keehan, who seems to be the common denominator for the 100% clinic show rate, meaning that every patient that day showed up for their appointment. On the other hand, we don't feel like we have as much control over what happens in terms of how busy clinics are and how busy the hospital is, but we did try to do a couple of things to make it a little bit easier for our busy residents.
We this year kept though we had a very strong emphasis on our in-person attendance, we did keep our conferences hybrid this year. So anybody who was off-site still had the virtual option to be able to attend conference should they want to participate in learning. The other thing that we did is 30 minutes before conference would start in the afternoon, one of us would take a lap around the units, just serving as a physical reminder to our teams, especially the ones that were still rounding, that it was time to maybe take a break, wrap up what they were working on so that our residents could get to conference. On a similar vein, we also send out text reminders via Volt and via Slack, the platform that our residency program uses to communicate to all of our residents to just nudge them and remind them that conference would be starting soon and what the topic might be. All right, the next barrier that was identified was space. So as you might be able to see from this photo here, sometimes the conference room that we are using is a little bit of a tight squeeze for our large residency group. And as Dr. Mary Leonard had once mentioned earlier this year, sometimes conferences could be standing room only. Another space-related topic that came up was that some residents thought our conference room, which is, for those of you who haven't been, it's just down the hall here, seemed a little bit far. It was across the hospital from some of their patients, and it was across the hospital from the cafeteria where food was. The last space-related thing that came up that some of you might be aware of is that Stanford is growing, and this part of the hospital is undergoing renovation. And with that comes the ever-calming noise of drilling and hammering, and the potential that Stanford might have other plans for this space that we were trying to make home again. So to address these space-related barriers and threats, we did a few things. The first is that this year we tried to promote conference being from 12 to 1 for noon conference, but we didn't start conference until actually 12:15 to allow residents the time to get food and then make their way over to the boardroom. The second thing we did is we brought back coffee, which seems simple, but was actually a really large endeavor for us. And we hope that this removed at least one pit stop for some of our attendees in the morning and actually incentivized some people to make it to conference. Third, we talked to Lynn, we talked to Jill Sullivan, who was our Senior Vice President of Strategic Space Planning, and we discussed with her the importance of resident educational space. And she was kind enough to share with us the beautiful new plans and vision for the West Building that is undergoing renovation right now, and also kindly shared with us that our conference room wasn't going anywhere. Along that veins related to construction, we met with Lynn Aguilera, who was so kind enough to be with us here today, who connected us with so many important people, including Steve Beju, the construction team, all of whom were so collaborative and worked with us to pause drilling underneath the boardroom during our educational time. So thank you so much. They were also so kind that when the drilling would unexpectedly start up again and we had to make quick phone calls, they would help us troubleshoot that. So thank you. All right, the fourth barrier that we addressed was protected time. So Volt phones. These are our cell phones that our residents use to communicate with people when they're in the hospital. They're wonderful because they make it so easy for people to get in touch with you. But they're also not wonderful because they make it so easy for people to get in touch with you. And it's really hard sometimes to be present when your phone is just going off all the time. We know that at Stanford, the conference culture had really been lost over the past 3 years, and we had a lot of re-education to do. So every day, we would send a message similar to this one and broadcast it to all the nurses, the case managers, working on our acute care floors and in the intensive care unit. We would share with them when the educational time would be for that day, and we would ask them, if you have any urgent questions, please send them in the next 15 minutes. Otherwise, please hold it until conference is done, for the morning or the afternoon. We've been so lucky that we've only been met with support and positive feedback from our nurses and our case managers. And truly, we are so appreciative of their partnership in making sure that we can prioritize our educational time. All right, last but not least, the fifth barrier we had to address was the #1 commonly cited barrier, which is team awareness and support. What was interesting is that in the surveys that we sent out, we also asked not only what were the barriers that you were facing, but what is the number one facilitator for you getting to conference as residents? And the number one answer to both barriers and facilitators was this: team awareness and support. Meaning that if attendings, fellows, and senior residents were aware of and encouraged conference attendance, then our residents would go. But if they were unaware of it, they disapproved of it, or they deprioritized it, our residents wouldn't necessarily go. And so what did we do? We've already told you, we've talked to everybody who would listen. We met with the division chiefs to share with them our vision and our initiatives. We met with our rotation directors. We also got our morning report series approved for CME. So we got it approved as a recurrent seminar series, so any faculty who would attend and participate would be able to claim CME. And Magna Patel, who is the manager of this, has been so instrumental and so diligent in making sure all of our speakers signed their disclosure forms so that our faculty could claim this CME every morning. And lastly, for those of you who might not be familiar, before I jump into this, I want to share with you that our resident schedules are such that they rotate sites every 2 to 4 weeks. Sometimes they're here in the hospital, then they'll switch off service and go to the clinics. And so every time one of our senior residents would come back and work in the hospital here, we would send them an email, this one that you see here, that reminds them of their role in conference attendance for their team, since they're the clinical, or they're leading their clinical team, trying to equip them with a few tools that might make it a little bit easier for them to get buy-in from their team as well. As you can see, in trying to get from where we were to our dream state of where conference culture could be, we had to approach this from so many different ways. On this next slide here, you'll see all the different things, all the different things that we just talked about that we implemented this year.
Okay. So now heading into step 6, generating short-term wins. And really, in order to highlight what we were seeing and visualizing as our short-term wins, we really want to now lean into the kind of objective results of our data, so our attendance data as well as our resident survey responses. So, because we feel like this really is highlights how we were making progress in terms of our goals. And just as a review, our goals were to improve conference attendance and engagement, improve residents' perceptions of our conference culture, and 3, improve our residents' fund of knowledge and clinical reasoning skills. So for this first goal of conference attendance and engagement, so here's some of our data. We were able to retroactively pull Zoom data from the prior academic year, and we're able to identify that we had a median attendance of about 15 via Zoom. As you can see here, there were even some weeks in which it was under 10. Then, as Dr. Sedler described earlier, we meticulously collected that attendance data over the course of the academic year, and we're able to compare that. And here's a visualization of what our attendance looked like following our interventions. We ended up with a median attendance of about 31 following our interventions. And through a Wilcoxon test, the difference in medians between the pre and the post met significant statistical significance with a p-value of less than 0.001. As you can see, and as we hypothesized, we anticipated a drop after the start of the year when you're through that honeymoon period of everyone being back together. But we felt we were able to sustain our attendance over the course of the academic year, including during our peak viral surge months of November through January. We are here being fully transparent with you. We also note there was that drop in April, which we have our theories and hypotheses behind, a little out of the scope for our presentation today. But as you can see, our attendance in May has headed back up into our medians in our 30s.
Numbers are only part of the story, though. So we wanted to return back to some of the images that we shared with you at the beginning. The pandemic learning environment with Zoom left so much to be desired, with cameras off, low attendance, learners that were disengaged, distracted. And when we tried to return back to in-person attendance, you might remember we still had low attendance. Do you remember this picture here with just one post-call resident coming? Our boardroom this year looks and feels different. As you can see here, our attendance has increased. Not only the residents, but our fellows, our faculty, our medical students. We even have APPs that join us for learning sometimes. We have increased engagement, increased discussion, increased enthusiasm about learning from both the faculty or fellows or speakers who are presenting and those who are there learning. And we want to touch on the hidden curriculum of having a good conference culture too. We also feel like we've been building community and there's increased community. And we see this in those little moments where our residents are able to catch up before or after conference as they're walking back to the wards. One more picture. So our residents not only rotate here, but they also rotate over at Santa Clara Valley Medical Center. We knew that in order to affect change at throughout a residency program, we had to make change at all the major sites that our residents were rotating at. So though we did not collect official data for our conference interventions and attendance at Santa Clara Valley, we did notice a huge increase in attendance as well. Conferences there were essentially non-existent. And here are some photos that you can see, just two examples of learning happening in morning report in the PICU conference room led by future chief resident, Dr. Faye Mendoza, and noon conference on the rooftop, getting some sunshine, taught by who some of you might recognize, one of our former chiefs, Dr. Lee Trope.
Okay, so going back now to our second goal of residents' perceptions of residents' perceptions of our conference culture here at Stanford. We're going to showcase some of our survey data response to our resident perspectives. Our first survey response question was that we wish to highlight is that we have a good culture of conference attendance. As a review, we looked at, each resident responded whether they strongly disagreed, were neutral, agreed, or strongly agreed with each question. In our pre-intervention survey, 87% of residents either strongly disagreed or disagree that we had a good conference culture attendance. We then, as a review, gave our subsequent iterations of our surveys and found significantly improved positive perceptions over time. With 72% agreeing or strongly agreeing in the last iteration of our survey. And in a NOVA F test, comparing the mean between the pre and the post data, we found statistical significance with a p-value of less than 0.001. Another measure that we think highlights progress in this space is the response to the survey question of our conference time feels protected from clinical obligations. Prior to the intervention, we found that 81% of residents disagreed or strongly disagreed with this statement, and only one resident said that they agreed that they felt protected. But after our interventions, including what Dr. Nguyen had highlighted earlier, including our messages to nurses and such, we did see statistically significant improvement. With our last survey intervention in May, the 81% fell to just 21% either strongly disagreeing or disagreeing, and then our 1% or 2% increased to 34% feeling protected. We recognize there's still work to do in this space, but we think this does highlight a significant improvement. Stepping away for a second from our survey, this was not related to our survey, but this was the ACGME survey from this past year. And we just highlight this because we found it was consistent with what we're showing. So before the pandemic, in spring 2020 to spring 2022, we saw a 20% decline in the response to feeling protected time to participate in structured activities. And after just over the course of this past year, from 2022 to the 2023 ACGME survey, we found 20% improvement. So we're back to where we were before the pandemic. The last measure that we just want to highlight at this time from our resident surveys was the response to the point of whether our conferences are preparing us for our pediatric board exams. We think this one's really important in the context of it demonstrates that residents are finding our conferences helpful and productive, and as well gets back into that other goal of just overall improving our residents' fund of knowledge. So as you saw before our intervention, only 36% of residents agreed that they felt our conferences were preparing them for our board exams. And then after, this increased to 82% agreeing or strongly agreeing that we had conferences that were preparing them for board exams, and this also met statistical significance.
We also wanted to mention that we collected so much rich data for this year and still have a lot to learn from the data that we didn't show you here. And so with our amazing statistician, Dr. Victor Ritter's help, we plan to still look at comparing team and hospital censuses with attendance as a surrogate for a measure of whether being busy in the hospital affects your ability to come to conference. We also are going to use the attendance list to back extrapolate what rotation the residents were on at the time and see if there's particular rotations that are making it to conference less, to see if there are any hotspots where we can help with improvement. And then we also sent out a faculty survey recently. Thank you to all of those of you who participated. And we're excited to be able to go through and analyze those quantitative perspectives. But from a qualitative perspective, we did hear from faculty that they enjoy being a part of and teaching to the larger crowd of rooms, and that residents seem more engaged than they were in the past. And then finally, we are excited to see the ITE scores in this August of 2023, although we do recognize we won't be able to take all the credit if there is a positive turn. We wanted to take a moment and acknowledge the steps 4 through 6 were really that engage and enable an iterative process. And now that we've made it through 1 through 6, we really just kept going back and back and back and addressing those barriers. And we thought that that was going to be the hard part. But frankly, I think that now we're at the hard part in step 7, which is to sustain acceleration. In our analogy of reviving conferences on ECMO, we sort of feel like step 7 is when you finally stabilized your patient. It's still tenuous, but things are not yet on autopilot. And we need to continue to address barriers, to make improvements, and continue to help others understand the importance of an educational curriculum that sustains resident knowledge regardless of census, regardless of surge or rotation. And so now that conferences are stable, we are ready to metaphorically decannulate, but we are holding our breath.
All right. Last step, step 8, embedding change into culture. We know that once we are able to embed this change into culture, we'll start to see longer term results like increased fund of knowledge, increased and improved clinical reasoning skills. This is our goal number 3. Goal number 3 in terms of our original objectives when we first started off on this mission. We know that our residents have learned a lot this year. And we know this because one of us is present at probably 99% of the conferences that we've helped organize. And what we're doing there, besides collecting all this data, is also taking notes for our residents so that they can be fully present and just listen and learn. And we take these notes in this format that you see here and in this document that we've come to love called Clinical Pearls. It's essentially a living repository of all the teaching points that have been taught by our speakers that they want to make sure our residents take away for the year. I think we looked back at it this week, and in preparation for this, we saw that that document is 392 pages long and counting. And we hope that this resource is there for the residents for when they're in clinic, when they're on the wards, when they're like, ooh, I think I remember learning this in morning report earlier, that they can use it and just do a quick Control F to find out what they had learned. We hope that it might even be something that they use when they're board studying. So we hope all of this knowledge, those 392 pages and counting, translates to fund of knowledge as well. Is it okay if we go back one slide? So we hope that when our residents take their boards, that they feel like they've been prepared, and that it translates to increased boards pass rate and to increased ITE scores this year, though we'll take some credit if it does go up. Most importantly, though, we hope it translates to clinical care. So As chief residents, we have the opportunity to work in urgent care and on the wards with our residents. And earlier this year, when I was on service, Dr. Eliza Phillips had given a beautiful morning report on complicated community-acquired pneumonia. And that same day, our medical students and residents brought what she taught about the management guidelines from the IDSA, their Infectious Disease Society of America, to the bedside and proposed next steps in care for our patient. It's in moments like these when we see our residents taking what they learned from conference, using it in real time to further patient care, that we know that our residents, or what we're doing, is making a difference and culture change has started. Now, to our residents, we want to take this moment to thank all of you. I think many of you are here, some back here. Your enthusiasm and dedication have made it so easy for us to be passionate about this project. You show up, you own your education, and in the process, you teach us. And you make it so easy for us to be proud of you. Now, over the past 2.5 years, it's taken 2.5 years for us to get to this point, and it's going to take time for culture to get back to where it was pre-pandemic and beyond. And it's bittersweet, but chief year is only a 1-year role, and in two short weeks, we're going to be passing the torch to these 4 incredible humans that you see here. We have Dr. Kleshi Bazy, Dr. Aiden Zahedovich, Dr. Faye Mendoza, and Dr. Aditi Reddy. They're going to be your next set of chief residents, but it's not just their responsibility to keep the momentum up. This is Stanford Children's Health Mission: extraordinary care, continual learning, and breakthrough discoveries. As an academic center and a training site, it is all of our responsibilities to train the next generation of pediatric physicians. We are entrusting you with the education of our residents.
Nurses and faculty, these residents are your colleagues, past, present, and future. Parents, these are the doctors that will be taking care of all of your children.
In administration, your frontline providers are often the first impression that your patients have when they walk into our clinics and our hospitals. So it's important for all of us to take their education seriously.
Actually, these are the residents whose education we are entrusting you with.
And these are the ones that will be joining you in just 2 short days. There's some of them in the back right now, the new interns.
So we leave you with this. It took a village for us to get to where we are today. And we hope we've demonstrated that with all the people it took to help us effectively make some of the changes that we discussed in our presentation. And it's up to this village now what happens next. What kind of care do you want your providers giving to our patients?
What kind of education do you want your future fellows and coworkers to have?
What is the type of doctor you want at bedside taking care of your child?
I'm going to make a call back to one of the grand round speakers from earlier this year. We strongly believe that Stanford Pediatrics can train the best, the boldest, and the brightest. The post-resuscitation care of our conferences and our residents' education is now in all of your hands.
Sorry for time.
That was incredible, Chiefs. Thank you so much. We could not have resuscitated our conferences without the hard work of these chiefs who took a rigorous and robust approach to engaging all of our stakeholders, improving the quality of conferences, and so many other interventions. So I am grateful. This is a gift to me. It's a gift to our residents. It's a gift to our patients. So thank you, thank you, thank you. And one more round of applause. At the beginning of each year, our chiefs get to choose what they want to focus on. And the chiefs asked me for some thoughts on what the biggest need was. And I said, if there's any way you can fix conferences, that would be the biggest gift to me and our institution. And they did it. So thank you. We do have a question in the chat, and then we'll take any live questions as well. And this is from one of our recent residency alumni, Dr. Dayan, who asked, at other institutions, faculty members participate in morning report, noon conference, or both. Why don't we do that here? And how do you think that might impact the culture of resident education if we did?
We would love to have our faculty, fellows, and attendings participate. That was part of our thought behind getting our morning report recognized as a recurring seminar series so that we could offer CME to faculty who attended, hoping that that would be something that brought them in. When we do have our faculty attend and participate, it really does enrich the learning and enrich the conversation. And so we would love for that to be a part of the culture change. And then, like Dr. Nguyen mentioned in our surveys, the residents also talked about having that support from faculty to go to conference was also really huge. So we would love to have that be a continuous part of change in the future. Again, thank you to all the faculty who have participated and made it out to our conferences and taught, and we hope that that continues to be a way in the future.
Our faculty may not realize how much our residents love you all, and so they want more time with you. Becky.
Oh my goodness, this was incredible. You four have taken such a rigorous approach to how we look at this problem. And I know nationally, this is a huge area of discussion. The American Board of Pediatrics, ACGME, APPD, we're all discussing this. You have demonstrated such incredible local solutions. Is there anything that can be done nationally? Or is this truly a local problem? Because I will say this is a national problem across institutions, and other prestigious places also had a 4% attendance rate recently. So.
we all have thoughts on this. We're all very excited about it. So I think the answer is it's both, right? I think a lot of this is an institutional problem, but I think, as we are all sitting on our APPD committees and ACGME, and there are national bodies that can be really guiding residency programs and making sure that this remains a priority. I mean, I think it actually, having those ACGME survey results from our national body and the ACGME putting pressure on us as an institution to respond to these comments actually gave us a lot of, it empowered us to really advocate for change. And I think that's the role that our national bodies can really have in kind of advocating for that.
We had a discussion at APPD with some of the other chief residents during a forum and talked about how this was an issue with everyone. And what we found very interesting is that everybody structures their conferences so differently and have different size programs and different resources that I think it would be tough to have like one thing that really helped everyone. And I think it really does have to be individualized and customized for the programs.
I think one novel thing we did was use this Cotter's 8-step for change, which can be something that can be extrapolated to other programs. We're hoping to share our methodology so that other programs can learn from that and use those methods to figure out what are the driving factors that are preventing people or helping people get to their conferences so they can institute change.
You're all going on a traveling speaking roadshow after this, right? Because that was awesome. Thanks so much for doing this. You just mentioned that you were going to share some of your findings with other programs, which I absolutely think you should. Was there anything you learned from other programs throughout this process, other chiefs that just stood out with you and said, we should implement this?
First of all, thank you, Dr. Alok Patel, not only for that question, but for helping us through 2 sessions that we attended on giving conferences and speaking and helping to inspire us for this grand rounds. We appreciate your guidance. It's not true. But I don't know if you guys had thoughts on this, but I think that when we spoke to other places, one of the things that they did differently is they adjusted the time of the day that they had their conferences. And so we toyed a lot with kind of switching the timing and the number of days that we had conferences. So we did reduce the number of conferences per week that we had, hoping that giving people some like sunshine conferences or free times throughout the week helps to alleviate some of the burden of going to conference like every single day. So that is one of the things that we took from them. I don't know if there was anything else that you. Oh, the CME credit. Yeah, we took that from one of the other institutions as well, talked about how they offered CME credit. And we were like, that's a great idea. Maybe we can figure that out. So thank you, Magna Patel.
And I was going to say, building on that, one of the things we intentionally did not take from other institutions, and I maybe we didn't highlight this as much because it was something that was really core to what we were doing, which is we didn't want to be penalizing our residents. They work so hard. We didn't want to be using shame or punishment as a sort of incentive factor, which we had seen some other institutions try to emulate by like taking away funding for like step 3 or things like that. So we were inspired to stay away from those sorts of interventions.
We hoped that if the educational conferences were interactive and they felt like they were learning, they would want to come. So we focused more on the content itself.
I just wanted to echo everyone and thanking you guys for this amazing work. And I wanted to make sure that you're going to publish this because I think not only for residency education, but for just the idea of culture change. Like I think a lot of us have been struggling with that after COVID. And so it's so inspiring to see that it can actually be done. And we can actually, I mean, I feel like the fellows should take this, faculty with their division meetings should take this. So thanks, nice work.
Thank you so much. We have one more question in the chat from Dr. Cohen, Ron Cohen. You started with residents not having seen asthma patients. What can we do about that problem and how to fix it? Conferences are not enough.
I completely agree. I think that problem fixed itself this winter. I know we saw a lot of lower censuses during the pandemic, but that is no longer the case as we were surging through this winter. And I think that our residents have now had a lot of exposure to respiratory illnesses, and I think that's been remedied. Should we encounter something like this in the future, another pandemic? Obviously, this was our very first time as a program navigating this, and I think we would definitely be thoughtful about the rotations residents were on and what they were having exposure to, but hindsight's 2020. I think that's something we will think about for the next global pandemic.
Well, thank you all for coming, and another huge round of applause for our amazing chief residents.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.